It's an absolute delight to be here. So many familiar faces, and it's really an honor to follow both Ian and Melina. And just just really struck by just Ian's story and how a lot of it has been what I've devoted the better part of the last 10 years to try to help folks with. Here are my disclosures, and it's always great to see such a focus on the patient at these seminars and these webinars. So I just want to start off with a case we saw recently in our multidisciplinary program. There's a lovely 62-year-old grandmother I've been seeing now for a while. This is an older patient, but she had recently diagnosed diabetes and at risk, fibrotic MASH. And like many of our patients, she was not quite at that magical guideline-based amount of activity and was consuming a diet that would make Melina cringe. And when we talked, she said, "Hey, my PCP is fabulous. They told me to lose weight and wants me to start metformin. But I know diet and exercise are good. They introduced the topic, but you're a liver specialist, so why would exercise be helpful for my liver?" And we get a lot of pushback on this, especially now that we have two conditionally approved medications in the form of resmetirom and semaglutide. But even with these meds, eating a healthy diet and being active is still going to be the cornerstone and augment some of the pharmacologic therapies. So we really want to make sure that our patients are convinced of all the fabulous benefits of exercise, right? We all know that it's good for us, but in terms of the liver, what can it do for you? Well, if you perform that magical 150 minutes per week of walking, you're actually going to lose fat in your liver. And the great thing is you don't have to lose any body weight. You can lose 2 to 3% of your body weight and still achieve clinically significant reductions of liver fat, which have sustained over time a lessen MASH activity and lead to MASH resolution. And we don't quite know yet if you just exercise and don't lose weight, if the scar tissue or fibrosis gets better, but we do suspect this will happen over time. And hopefully, if I'm invited back, I can share more data with you in the upcoming years. But it's not just about the liver, right? Exercise is a magical treatment. It does so many different things at once. It's going to, of course, increase your fitness, change your body composition where you have more muscle, less body fat. And through this will lower your cardiovascular and metabolic risk. But again, it's not always about the numbers. It's about how we feel. So folks who engage in regular physical activity feel a lot better. And I'm sure Ian can talk about a lot of his clients. But again, we've heard how behavioral change is really hard to do. And at least in the United States, medical students who are training to become MDs spend 0 minutes of their time over 4 years learning how to prescribe exercise. So I'm not going to make everybody an expert in the next 7 minutes, but I want to introduce a very brief framework you can do every time. And one of the frameworks we use for behavioral intervention is called SBIRT. We heard about SMART from Melina, but for this one, S stands for screening, BI is brief intervention, and RT is referral for treatment. And I'm going to walk you through this now. So in terms of screening, the question is, who do we screen and how do we do it? And luckily for us, the American College of Sports Medicine makes it easy. It says we screen everybody, and we screen everybody at every visit. Sounds like a lofty goal, right? 2 out of 5 people worldwide, at least if you're an adult, are living with MASLD. So we got to have a tool that works, and we have to have a tool that's cheap, it's cost effective, and it's easy to do. So we have the physical activity vital sign. And if you do these 2 questions, you can actually figure out from your patient what they're currently doing. And we've heard that, people have a tough time achieving guideline-based amounts of activity. So if your initial questionnaire and screening discovers, what they're currently doing isn't enough, the next question is why not? And Ian told us many different reasons that people experience, some of which are unique, some of which we see at a population level. We have an internal questionnaire which actually screens for this with 13 questions. And it arrives at many of the things that he showed us as common barriers. So once you've taken this questionnaire and you find what your patients are doing, and then you find what prevents them from doing more, the next question is, what are they capable of doing? And I'm not going to send everybody to Ian to do formal exercise testing on a treadmill, right? So we have to have another way to approximate fitness. And luckily, we have what's called the DASI, the Duke Activity Status Index. And with this questionnaire, which again is cheap, it can be done in less than 2 minutes, you can figure out somebody's current fitness level, at least from an aerobic standpoint. So that's screening. So again, what is your patient doing? What prevents them from doing more if they're not meeting guidelines? And then what are they capable of doing? So you already have this idea in your head of how you're going to design a way to help somebody be more active that is realistic and it's personalized. The next part of this framework is brief intervention, and that's your time to shine. That's when you tell people all the fabulous benefits of exercise, both for your liver and then outside. But if we look at how we're actually doing as a medical community, we're not doing very well in delivering this information to our patients. And we've heard some of that today. And in fact, only 3 out of 4 people living with MASLD receive lifestyle counseling from their healthcare providers. Only 1 out of 2 are referred to a dietitian, and only 1 out of 10 see an exercise professional. So we need to have tools to make this better. And if we're not referring patients for treatment, perhaps we can do this ourselves. And Melina was gracious enough to show this earlier, where we have developed this MASLD exercise prescription form. And this day and age, everything is digital, right? So when you give patients that piece of paper, it really makes a difference. And you can give them more than one. So that way you have this progressive program you design where you start low and you build up to that magical guideline-based amount of activity that's going to do all those fabulous things. And you may say, well, how do I design a prescription? How do I know what to circle? Well, ACSM has a nice framework. It's called FIT, easy to remember for exercise, right? And we'll just walk through this briefly, but frequency, is how often you do activity. Intensity is how hard, and time and type are self-explanatory. So when you're looking at this prescription pad, you have some choices. How many days a week do I want somebody to do aerobic training? And 3 to 5 will be sufficient once they progress to that amount you want them at. And then resistance training is helpful on 2 non-consecutive days. In the interest of time, we're just going to skip through the rest of these. The slides will be provided. There'll be some QR codes for all the tools. And if you don't want to remember all this, American College of Sports Medicine has a fabulous handout you can give to your patients, which summarize at least the goal they want to get to while you build that progressive program. Now, another great thing, at least here in the United States, is actually ACSM has a professional database called ProFinder. So if you don't want to do this yourself, you just want to refer to a friend, it's very easy to get somebody at the level of training that you think is going to help your patients. Now, what happens if we put this all together? If we do the screening questionnaires, we do that brief intervention just with an exercise handout, and then we hand people that individualized prescription. Well, it turns out you can actually turn people from not completing guideline-based amounts of activity to those that can actually complete this. And it's not seeing a trainer. It is not anything that's systematic. It's literally just you spend time as the clinician and you outline this program. People will get where you want them to be. And you may say, hey, well, John, I can't do this. I'm a busy primary care provider. I have to address 7 different problems. But I'm here to tell you can. The screening process begins when you're not even in the room. And if you're like me, you're always behind. You spend a lot of time talking with folks. But you can give people the questions when they reach the door. They fill them out before you get in. We're all speed readers. And then you got to practice your brief intervention. Look in the mirror, rehearse, and say, why is exercise good? And walk through the simple steps. And then lastly, have a plan for how to refer. And I guarantee you can get this down to 5 minutes or less. So you can do it. It just takes practice. So back to our patient. So we enacted the physical activity playbook for this lovely grandmother. And we ultimately, got her to do an in-person and combined commercial fitness program. And like many folks, she struggled with consistency in the beginning. But after 3 months, she got to that magical amount of aerobic activity plus 2 sessions of resistance training. And when we saw her back in 6 months, she wasn't too fired up about her weight loss. But when we did her fiber scan, her liver fat and liver stiffness improved, and she had a reduction in her metabolic risk. But the most heartwarming part of her visit is she said, hey, John, I can't wait to go home and exercise. Can you please stop? Tell me why it's so great. You're interrupting my time. And with that, thank you very much for your time and attention, and happy to take questions that we have time.